Hello, and thank you for joining us for this interview between Dr. Costa and Linda Moss. The goal of the patient journey is to capture and understand the experiences of those who have been impacted by wounds. When Linda shares her story, you will learn about her experiences as a daughter whose father suffered from a severe pressure ulcer after being hospitalized. If you would like to learn more or participate in this project, please reach out to one of the emails listed below.
Thank you so much, Linda, for staying with us and for your willingness to connect and share the story of your dad. So this way others can learn and prevent the same situation from happening. We really want to increase our stories, get more stories so we can build more effective advocacy and change policy. Okay, so let's start by asking you the first question, which is for you to tell me more about what happened to your dad.
Absolutely, and thank you, Edie, for this opportunity. It's kind of fallen into our lap, and to be honest, we're honored to speak about it because I think it's very important. When this story first hit national news, it was the cover story, and it reached out to millions of people, and I never knew how much of an issue it was. It hit me afterwards, and when there was thousands of comments and I couldn't keep up, I just thought, oh my God, first, I'm not alone. And second is this is a major issue. What can I do about it? But to rewind, I'll just tell you a little bit about my dad. So my dad, Bob Wilson, was a very active 77-year-old. He was a avid golfer. He would probably travel 4 times a year to the sunny Florida Keys or wherever to golf. And he was a weekly bowler as well. But most of all, he was a devoted father and grandfather, and he loved hanging out with us daughters. So when we got the call November 29th in 2018 that he fell down the stairs, we were scared and we didn't know how serious it was. So we all rushed to the hospital, and he fell just taking out the recycling. So it was something that happened at home. It can happen to any of us. He had emergency brain surgery and was in ICU at Hospital 1 for 9 days. And he did well. The brain surgery was successful. And then he was transferred to Hospital 2, where he first arrived in ICU. And then several months later, he was remained at that hospital.
Okay, so you said that he went to, after the surgery, he went to the ICU, which recover, which is normal. Yeah. So how long he stayed in that ICU, do you remember?
He was in for Hospital 1, 9 days, and then he was transferred to ICU at Hospital 2 for probably 2 weeks. He was there, and then he was gone to the inpatient ward. So it was several months that he was at that hospital, and he was doing really well. From probably December to February, we worked tirelessly, me and my sisters, to help in his recovery and to bring him back to us. We did several tasks with him. We taught him several things. We basically had to rehabilitate him again. And he was doing really well, and he was trying to get up off his seat. He knew how to communicate. He could identify who each one of us was. He was coming back to us, and this was around February. So we were there for several months, and we were probably a model family to the hospital. We respected all of the medical teams, and we appreciated all of the help that they were doing to bring our dad back.
Okay. So I want to be clear in terms of how long he stayed in Hospital 1, yeah. And if you know which hospital he developed that pressure ulcer.
Yes. So you want me to say the hospital? name?
Yes.
Yeah.
No, don't say the names. No.
Okay.
I just want to know, for example, hospital number 1 was
Yeah.
where he did a surgery.
Yeah.
So he went from OR, operational room,
Yeah.
and then went to ICU, all right?
Yes.
And then in the ICU, he stayed, do you remember how long?
So hospital 1, he was in ICU from November 29th when he fell to 9 days after that. So he arrived at hospital 2 in the other ICU in December.
And why he was transferred from one to another?
I think because he lived in Burlington, so they transferred him to his hometown hospital, and the brain surgery was successful. So now it was a matter of recovery.
Okay.
So yeah, so they transferred him to a closer hospital, so all of us family could visit a lot easier.
Okay. Being ICU places a person at high risk to develop pressure injury.
Mm-hmm.
I don't know if you know that. And that's why, but there are still ways to prevent.
Yes.
Okay? There are still ways to prevent. So knowing how long he stayed in one ICU and knowing where he developed this, were in the first one or in the second one? Did you ever was told?
No.
Or did you discover after?
So after several months of rehabilitating our dad, we focused highly on the brain. Nothing else was told to us. So I think that's where the disconnect is, and something that I'm very passionate about is when your loved one is admitted into the hospital, they're admitted in for basically option A. So he was admitted into the hospital for brain surgery. However, I think that's where the transparency comes in, and a care plan is very important, that your dad is in here for A, however, he could develop B or C while he's in here. And this is what we want to do to make sure that that doesn't happen. So we did ask for a meeting when he was transferred to hospital 2, because he would be there for a while. So we did ask for a meeting with the doctor and the teams involved. However, we had to ask for it. So I think that should be something that's really important when a patient is admitted into a hospital, is a care plan with the family members week 1. So February, so up to November when he fell, he was doing really well until February. In February, we started to notice a decline, and we couldn't figure out why he was declining all of a sudden. He was getting infections and fevers, and several tests later, they still couldn't figure out why he was declining. So we did everything and anything to research his brain and anything that we could to help him. We kept thinking that it was part of the problem was he was missing half of his bone flap. So we kept advocating to get the bone flap reconstruction done, thinking that it may bring his cognizant back, or the juices would come up and circulate his brain, and all of a sudden, bang and pop, he would come back to us. But so they were willing to do that, to go back to hospital 1. He would have to go back and be transferred to get that surgery done again. However, he kept getting infections and fevers, and the surgeries kept getting canceled. At one point in February, he aspirated and had pneumonia, so the surgery was canceled. At another point, there was a snowstorm, so that surgery was canceled. So we kept doing what we were doing, still baffled, figuring out why is he declining. And then it just so happened on March 27th, I remember I've always seen the bandages in his room, but I never really asked. And at that particular day, March 27th, I asked the nurse, what are these bandages for? I'm assuming that he may have a sore on his back end. And she said, yes, he's starting to develop a wound, but it's the size of a toonie. It's red and irritated, and we're taking care of it. So that was the first time that we heard of the wound. But we were so focused on his brain and they were taking care of it, we didn't think anything of it. When I look back now, I wish we educated ourselves on a pressure ulcer. So if we would have known way back, maybe in January or even December, that a pressure ulcer could develop, we could have educated ourselves on that. Or if the medical team or the doctor educated us that this could be an issue, and this is what we're going to do to prevent that.
Okay.
So that was the first time I found out about the wound, was March 27th.
Mm-hmm. And now, after this time, were you able to get the information of where the wound was developed, hospital 1 or B or 2?
Hospital 2. So he was in hospital 2 for 5 months. So he was, so that was the most of his stay, was there. Our dad couldn't communicate with us because he had a trach. So he couldn't really tell us what was going on. He could point to us before that and know who we were. He could do a thumbs up, thumbs down. He could do yes or no communication, but that was it. But to be honest, we didn't really think anything of the wound at that time. And then it wasn't until a month later, we got the call that he was being transferred back to hospital 1 to do the reconstructive surgery on his brain. And we were so excited because that's what we were advocating for. Mm-hmm. And so April 21st, he was transferred back to hospital 1. And then we got the call on April 22nd for the family to come in. So we came in April 22nd. So to be honest, that is when we first found out about the wound, because the surgeon that was about to help with the surgery had to give us the devastating news that the surgery was canceled for the 4th time. And we were like, why? And then that is when she showed us her phone and she took a picture of that pressure ulcer that went viral around the internet. And I can show you the picture, Edie, or you may.
I remember the picture, but you can show.
Yeah, so this was the picture that was taken off of her phone.
Wow.
So that's my dad's bottom.
Mm-hmm.
And needless to say, shock was an understatement for our family. We had no idea. Even his primary physician not once mentioned a pressure ulcer to us the whole 5 months he was there. So, and the doctor who took the picture was baffled too, because she couldn't understand why we didn't know. And that was a really good question. Why weren't we told, right? So the first time we were told was March 27th when I asked, and it was the size of a toonie and red and irritated. So of course it's like a rug burn, didn't think anything of it, was they're taking care of it. So a month later to get to that point. So that is what's devastating about this. So needless to say, they had to race. So I think it's called RACE, because when he arrived at hospital 1 again, he was septus. He was in emaciated condition. That wound was full of feces and they had to save his life. So it was devastating because everything we focused on, which was his brain injury, suddenly shifted to now the pressure ulcer. And that was what was heartbreaking about all of this, is if we just had one person alert us, just one person say, you might want to have a conversation with the doctor because this wound is getting really bad. And there was no warning. There was not one person rang the bell or raised the flag and said, family, this is what's happening to your dad. We didn't know. And that is what hurt so much. So that's where we found out it was the communication breakdown, because the nurses thought the doctor was taking care of it. The doctor thought the nurses were taking care of it. The family didn't know about it. So week over week, it got worse and worse. And that's why I'm very passionate about speaking up and making sure this doesn't happen to any other family, because no one should go through the shock that we did. And we were there every day, Edie. We were there for 5-6 hours in a day. And You know,
There's
we were
no
very,
excuse me, yeah, for them to say you couldn't find the family. They left a message, because this can happen sometimes working with in ICU. I remember sometimes you try to reach out to the family and you don't find them.
yeah. So, you know, and our dad's room became a revolving door of doctors and nurses coming in to look at this wound, because some of them have never seen a wound this bad in their careers.
Yeah.
So how does it get to that point in our healthcare system where a wound gets to be black, dead, rotted skin and the family not even knowing about it? So, you know, it's heartbreaking for our family, because, you know, we don't want to finger point. We don't want to, we were angry about it and we were shocked about it. But now what I do is, how do we turn that anger into something positive so this doesn't happen again? It should not happen in our hospitals. So that's why I say that transparency and communication is critical in a care plan for every single hospital, every long-term care facility. This is preventable, and we could have helped. We could have done something to help. So
definitely. When March 27, you were able just to see the bandage. You didn't see the wound. Was that?
No,
because so you didn't know exactly how the wound, the appearance of the wound characteristics was.
No,
and
it was
the nurses brush up or just like.
Okay. Yeah, it was when, to be honest, I didn't even know what a bed sore was. I didn't even know what a wound was, and many people don't. And so when our story hit the internet, it warned and it armed a lot of families that if you have a loved one that's immobile, this can happen, and it can happen fairly quickly. So if we only educated ourselves, or if we were educated by the medical teams that this could happen, it could have been preventable. Our dad may have been alive today. He may have required special needs with a brain injury, but he may have been alive, and we could have helped turn him. We were there all day, and we were told he was on an air mattress that moved him, and we felt the bed move. So we thought, okay, well, he's getting moved by the bed. But we were there, and we rarely saw him being turned, and we could have done that. So when he was at back to hospital 1, and they raced to save his life, he had a completely different care plan and way of them caring than they did at hospital 2. For example, hospital 2, he was always on an incline. So he was on a 33-degree angle incline, and he was rarely turned, and he was always on that wound. But at the time, we didn't know how bad it was. And when I think about he was on that wound, directly on that wound, it devastates me, because that's like torture. And when I think about the times that he would hold my hand really hard, or a tear came down. Sorry.
No problem.
Was it his way of saying, I'm in pain, or he was trying to tell us something? I don't know. And that haunts me. It haunts me because we could have done more, and we didn't, because we didn't know. And that is something I will live with. My family will live with. And that's why we want to make things better. So at hospital 1, he was never on that wound. So for a month, he was off that wound. He was on his side, and he was almost lying flat. So how does that work with 2 different hospitals having 2 different care plans and different ways of how they treat it? And that's why I'm passionate about talking too, because I think there needs to be consistency in hospitals on pressure ulcers, and policies and procedures need to change. And there needs to be a better way to handle these patients and to make sure the care is there.
Definitely. Wow, that's very heartbreaking story, and listen to all this of this. makes us just to reflect, and definitely needs to have consistency between these hospitals.
Yeah.
And the best practice there for everyone. Yeah, just a
Yeah.
matter of having the willingness to implement those best practice, and train the staff to
Yeah.
their job. Linda, I just wrote here what I want to ask you. When you saw that wound, you kind of already said, but I want to explore more, to expand more on this. When you saw the wound the first time that the doctor came, and I think you were all your family there, your
Yeah.
siblings?
So we all got called in.
All right. Yeah. Explain that. And I want to know, how did you feel and what came to your mind? And then after that, what did you discuss with your family about?
I think the biggest thing was shock, because when you look at that wound, how can you not be shocked? And how could, I think a lot of different emotions we felt. Shock was the biggest one. Our mouths dropped when we saw that, and I just couldn't believe it. Heartbreak was the second emotion, because we really loved that hospital. We really respected everyone that helped our dad. And it was heartbreaking because nobody said anything to us. And at the end of the day, you're putting bandages on that wound and walking away. So that was the biggest heartbreak, is because, and that's where I really push that communication is so important. And why weren't we alerted? And, you know, when I talk about tools and things that need to happen with a patient's care, is you had two different hospitals with two different ways of taking care of a patient, two different wound care bandages. So I don't know what's better than the other, but most importantly, we were devastated when we found that out, because now it wasn't a matter of he wasn't going to recover anymore. So it was a matter of trying to save his life at this point. Mm-hmm. So he was at that hospital for a month, and several antibiotics later, we got the news that the wound was so severe that it's now in his bone and now in his bloodstream, and he developed osteomyelitis. So how does it get to the point where he develops that, and the family don't even know about it? And the doctor never saw the wound. The doctor never saw it. So, you know, it's just all mind-boggling to us. It hit us like a hammer. And we got the devastating news the end of May that there was nothing more that they could do for our dad. And they recommended palliative care. Mm-hmm. So he was transferred to a third hospital. Thank God they took him into a beautiful room, where that was probably the most painful part of everything, was watching him pass away in front of us and knowing that there was nothing we could do to bring him back, and we didn't have a chance to save his life. And that is why I speak today, because I don't want this to happen to anyone else, and change needs to happen.
I feel so sorry for that, and especially because we know that it can be prevented, and there are so many things that could be done, and especially in the beginning. And getting to this point is getting to this point is like you are in the middle of nowhere. You have nothing to do, because you just walked away for so far from what could be done. It's kind of almost like you could be done something. It's like when you are running out of gas and you are traveling, you're on the street, and then now you're far from the station. You can't go back. You just need to be there and wait for a miracle. to
Well,
happen.
that's exactly it, Edie, is that we can't rewind, but we can only, like I say, go forward and make some change happen. I firmly believe with every tragedy, there's a lesson learned and a positive movement that can be made. And that's why I speak today, because there's so much that was learned from this. And to be honest, there was a lot of good that came out of this. As much as, we lost our dad, the hospital that he was at, they did a clean sweep of the hospital and they identified 22 patients that are immobile with pressure ulcers. So that was 22 people now that had a care plan, and perhaps 22 lives that were saved because they did that clean sweep. Hospitals, I heard from hospitals across the country, of changes that they were doing. Some teachers at hospitals teach our dad's story of what not to do and what can happen. Like this was a never event. So how does a never event happen at hospitals and it's not communicated? So it's just it's mind-boggling, but we can do better. And that's the big question, right? Is how do families work with the medical community? Because at the end of the day, we need them as much as they need us. So how do you work together and communicate together? And that really comes down to some kind of an onboarding. When patients or when families walk into this bright, big hospital and they see the hustle and bustle of everybody running all over the place, they're scared, they don't know what's happening with their loved one. So an onboarding is really important for families to discuss, okay, your loved one's in here for a while. This is what he's in for, and this is what we're doing. This is our care plan. But within that care plan, he could develop this or this, and we want to make sure that you're aware. And these are some of the things you family can do to help the medical teams and, to make their job easier. When I think about now, especially with COVID and the lack of families that can come in to help these patients, I firmly believe that a family advocate is crucial in the recovery and the medical, just the medical plans of helping these patients, because family is medicine, and family can really help the medical teams to do the things that are maybe tedious, getting a glass of water, grooming, supplying comforts for the family member, helping them turn. So these nurses can focus on the medical parts of the patient's recovery and not getting a button pressed every 2 seconds because they're cold or they need water or they can't plug in their phone. Like I hear it all the time. So the family members are just as important. And they are the eyes and the ears of the patients. Like I remember in my dad's recovery, when he was more animated, the physiotherapy would come in and he would always be sleeping. Well, with a brain injury, you sleep most of the day. But they would come in and on the reports, they wouldn't do much because he was sleeping. And I remember having a talk with them and asking them, well, we can't do much for your dad because he's always sleeping and he doesn't do anything. And I said, well, what do you mean he doesn't do anything? He said, well, we would come in and you'd be sleeping. I said, okay, well, let me show you a video of yesterday when he was trying to get up off the chair or he's throwing a bean bag. And they were shocked when I showed the video. And that's why I always say it's so important for family members to document their progress of the patient, because it's kind of like the Drake song, started from the bottom, now we're here. So you started here where you can't remember where you were, but now look at you and look at what you're doing. So when physiotherapy saw what he was doing on the video, they amped up and started to come in more to help him. But if I didn't show them the video, what would they have done? You know what I mean? So that's what I mean, like family advocates are the medical team's eyes and ears. They see more than what they do. And it's very important to have that communication. Well, look what my dad did today or yesterday. It helps them to plan in their care.
Yes, definitely. But Linda, you and your sister have been learning a lot from the situation. And if you can provide an advice for families that are just in the beginning, no, maybe they have a relative going to hospital, going for a surgery, and they don't know a lot, they don't know much of what are the role of family.
Yeah.
What would you tell to them in terms of what their role are?
Yeah.
And what their roles are, and what they could do to prevent pressure injury or any other poor outcome that you now learned, and you can speak with a concise and property on that.
Absolutely. I think most families, when they walk into that big bright hospital and it's very busy, it's very intimidating. I think the biggest thing they can do is one, after they get doctor time and find out what's wrong with their loved one, is really having a meeting like I talked about, and how can they be best of use and not be in the way, because the main thing is the care of the patient. But family members, really, they want to help. They just don't know how or what to do. So I think it's best to have that doctor time. And that's another thing too, is a lot of family members work 9 to 5, and it's very hard to get that doctor time and to figure out what the plan is. So I think that's really important for family members to have. Maybe there's a time on a Monday or something like that they can go into where the rounds happen, and just figure out and have that time with the doctor, because I know that the doctors have limited times, but it's really important that the families know what's going on with their loved one and how they can help. There's a lot of things that I learned when we were there, and not all family members can be there like we were. I would take my laptop and I would plug it in, and I would be with my dad all day, and I would do work from the hospital, or I would go after work. And me and my sisters would alternate, and we would go different days. So we always had somebody there with him. He was lucky. Not all patients are that lucky, and it's difficult. And then some families, perhaps English is their second language, and they just can't get that communication, and they feel very isolated because they're not understanding. One of the things that I tell a lot of families is document everything. And if you can write notes and educate yourself too, that way, if you educate yourself on what the issue is, you can ask some questions. And when you do get that doctor time, you can ask those questions and make sure that everybody is on the same page, that everything that you know about. So a lot of times that we've noticed, they would be plugging in another IV or something, and we didn't know what they were doing. So what is that you're plugging into our dad? What's that PIC line for, whatever? I think it's really important that communication and transparency is happening. And I think the nurses need to have that authority to do that, because a lot of the times we were told you have to review that with the doctor, but it's not always easy to get doctor time. So I think that's really important. I think a lot of the things one of the things I talk about with families is your best way is being there for them emotionally. And it's funny, some of the things that I thought of as when we were caring for our dad, I called them the 3 C's, because these were things that we just learned. And one was communication. Second one was comfort. So what can you bring from home? If he's going to be there for a while, what can you bring from home just to give them a little taste of home, whether it is your familiar blanket or slippers or pictures of family. We brought in a radio because I know that iPhones and electronics are expensive. So we brought in an old radio and we put on some good old oldies songs so he could listen to some music softly instead of hearing the beep, beep, beep of the medical sounds of the machines going all day. Yeah. What's more healing than listening to low music? It's soothing. And it's something that my dad we would come in and he would be bopping his feet to the music. A lot of times we'd come in. It was great because he would be listening to that radio station. But what was emotional for us is when we left that room to go to work or go home, we would put on that music station. And I knew that we were both listening to the same station and the same song at the same time. So it connected us. So I think something like that is really healing. So, and the other C is companionship and champion. You've got to have a companion. And with some families, with some patients that are in there, the family members are not always available to be there for them. So the nurses are the only face they may see, or the doctor. So that's where compassion comes in. And these are human beings that are sick and they need help, and they're not just another number. It's not room 119. It's Bob Wilson in room 119, or it's Mrs. Flanning or whoever. They're people, and they just need people to understand that they're not well, and they're scared too. So, so yeah, so I say that with family members, just be their comforts, bring comforts from home. Educate yourself, communication, questions. Have some questions for them, and just document everything. Take pictures, record everything. So you are their advocate.
And how about those families that are unsure if they have the right to ask questions, or if they would be bothering if they ask questions because they may feel maybe I'm not welcome? What do you think they could do to improve this communication when they perceive this line is not really visible? It's more some like things that they are scared of. How they go through with this?
You have every right to ask a question when it comes to your loved one, 100%. And the medical teams, I probably should appreciate the question, because that means you're involved and you care. So, it's not, a lot of families do feel that they're in the way when they're there, and they don't want to feel that way. So that's the biggest thing that I think medical teams and families need to do for each other, is how do the family members become useful? Because, you can't do the medical part of it, but there's a lot of things that family members can do that are useful, that really frees up the time of the medical teams. And knowing that, nurse, I got you. I got this and this and this for my family member. I can groom them. I can help me brush their teeth. I can do that. I can put lotion on. These are little things, but it frees up the nurses to really have that extra time with their patients, with all the patients, because they're stretched and they're stretched thin. And we understood that. And there may be some family members that think that it should be all upon the nurse to do all of that stuff. It shouldn't. So that's where the onboarding comes in, and the expectations come in for family members and the medical teams, that, this is where we can work together for the same common goal, and that's the patient. Yeah.
Very important. You already talk a little bit about the message for healthcare providers, and understanding this context now, where we see that families are not always welcome to ask questions, because also due to we need to understand how our system is rooted. It is rooted on a paternalist model, where healthcare providers know everything. They are there, they will take care of everything. They don't accept help because they are paternalist, okay? Yeah. So this is probably the way most of healthcare providers were trained and socialized. But now with these trends of family partner as a partner, you know,
Yeah.
healthcare provider and patient as a collaboration, shared decision making, all of these. How do you think we could work to improve our healthcare system to shift from paternalism to a more collaborative care approach where we can engage family and families?
No, absolutely. And I think, um, the medical teams are responsible for their patients, and there's liabilities and all of that stuff. So there's certain expectations that I think the medical teams need to make clear with the families that, okay, you're here, our job is this, and your job can be this, and this is where you can help me with your loved one. We don't want them touching machinery and pressing buttons and doing all that stuff. That's where we're not educated enough, and we're not experts. And I'm not an expert by any means. And I would never touch anything, any buttons or anything like that. But I think the biggest thing that families can do is just be there for them emotionally. So, there's the commercial of the Ronald McDonald House that goes around where it says family is medicine. It's very true. You need both. You need the medical teams to do their thing and make sure the right medications are going in. But also, one of the things that we discovered was our dad's nutritional feed was changed 2 weeks before he was transferred back to Hospital 1. So if this was developed earlier, I think it could have made a difference, because he was really getting skinny and they changed it to be more protein. And he was also diabetic. So we may not understand a lot of the medical things that they do, but we need to be told it so we could kind of understand this and know what's happening with our loved one. So, we're smarter than what they think, and give us the opportunity to learn and to know more, and talk to us while you're caring for the patients. Talk to us and tell us what you're doing. And if it's something that you can't really talk about and it goes to the doctor, then help us recite that question that we can ask, and make sure that we're all on the same page.
Perfect. While we were there as a family, what kind of support did you receive that you would want to highlight? Maybe you want to separate from hospital to hospital, just for being clear. Hospital 1, do you think your family received any support? Support, when I say support, is meaning, of course, they already told, like engaging our family in informations that were happening, making you aware of everything, or even saying you are welcome here, or we understand your pain, being compassionate towards you. I wanted you to see what kind of support you want to highlight that were there, that you want to highlight, say, yeah, this was great, kept us together, or this was lacking and we think that this need to be highlighted and need to be implemented or something. I want to talk now about family support.
Yeah, I think there is a huge difference in supports and care at each facility. We noticed a huge difference after our story hit the media. We became a high profile case. And I think the care that we got afterwards was top level, because it was now national news and people knew about it. And I wouldn't say because it made national news we got better care. I think at Hospital 1, it was great care from the beginning, and they really informed us what was going on. Hospital 2, they would come in and do their thing and then leave. we would ask questions, and we really respected, and we really got along well with the medical teams. I think there could be better, obviously there should be better transparency and better support for the families. You know, we would have someone who would be, what do you call it, patient support person, who would come in and would talk to us how we're feeling and stuff. That would come in, and but it was very infrequent. So I think you're going through a lot, and it's very emotional, especially 5 months of having a family member immobile in the hospital. That was our second home for the longest time. I think there could have been more support. I think the support happened after the fact. The support happened after we hit the media. The support happened with many different communities. The support from the public was overwhelming. They were outraged at what happened, but they also wanted to see change happen too. And it resonated with thousands of people who went through the same scenario. You know, the support also happened with lawyers and with doctors and with nurses that would come forward that wanted to make a change. When we spoke at Wounds Canada conference in Niagara, that was so eye-opening for us, and we heard from so many people. They heard us and they felt us, and they wanted to do better. We spoke to so many amazing people afterwards, and they understood what we went through. And that's why I think it's so important that the support is there for family members. They don't want to feel like a burden. They want to make sure that their family member is getting the care. So the support was on an unbalanced scale. So that's where I think we could do better, for sure.
The support was missed during the time that you needed mostly.
Yes.
And it came afterward, which can help from now others' families with your story. Definitely.
Yes.
Now I want you to thank you so much for answering all these questions, and it's amazing. Like, most of questions I even didn't ask because you covered.
Well, because I probably rambled on and
yeah, that's great. No problem. No problem. It's great because we are very synchronized, and you narrow very well your story. Like, your narrative is great. Now we talk about message to families, message to healthcare providers. I want you to leave a message for the government, for the policy makers, for those that can, the high level. And what do you think your story can teach them, and how they can get your story and make changes? What do you want to see for the future?
I wrote all this down.
You have the power now. The power is with you.
Yeah, no, I wrote all this down because this is why I speak. Because, you know, I do this for many different reasons. I do this because, one, I don't want another family member to go through this. Two, our story, we have a story to tell, and it was a pretty big one. And there needs to be change happening at high level at government. So the reason why I wrote this down is because each long-term facility needs to have a wound care specialist or some kind of a team member that's on board. At Hospital 2, they now have a specialist or a team on board. So that happens because of our dad's story. So they didn't have one before. It was more of a consultant that would come in, but she was not on site. So protocols and procedures need to change at every hospital. Like I talked about, it was a different plan at each hospital, and it needs to be consistent. I think that's really important. But not only that, I think new technology needs to happen at these care facilities. When I watched the nurses try to turn, and with wound care, you need to turn them every 2 hours, but the way that they're doing it, I think, is archaic, to be honest. You need 2 nurses to turn a body. It's not always easy to get to flag down another nurse to come help you to do it. And that's where the family members can come into play too, because they can help the nurses. But then you're propping up pillows, and so you need 6 or 8 pillows or whatever, maybe 4, I don't know, like to prop up the patient so they're off the wound. So there needs to be some kind of technology, not only to monitor the wound and to help it get better, but to keep off of that wound, because each facility did things differently. One hospital had him on an incline, another hospital had him lying flat. So where, you know what I mean? Like it just was inconsistent. So wound, after our story hit, there was millions of views. That pressure ulcer went viral. And what does that tell you? It tells you that many people are going through the same thing that we went through. Maybe not as severe, but pressure ulcers are not going away, and it is a major, major issue, and it needs to be on the forefront of any medical facility and long-term care facility, because people are dying and it's preventable. Mm-hmm. So that's what I want to say.
Needs to be on the prevention list of issues that can happen during hospitalization.
Absolutely.
Yeah, not
absolutely.
And it's very interesting because when a person is hospitalized, especially for surgery, the most concern is infection.
Yeah.
Okay, but an infection, like an ulcer, is an entry to infection.
Yeah.
So it needs to be there definitely on their list as concern. That needs to be on top of their list, and implementing preventive measures that could help them to not go to this situation.
No, absolutely. And even just documenting it and taking pictures week over week. You know, if we would have seen the wound, we could have done something about it. And as daughters, we're not going to look under those sheets, right? Yeah. But wounds is a silent killer, and it really is, and it's a cause of death. Mm-hmm. But to get to that point, you need to prevent it. Mm-hmm. So there's a lot of things that could be done through medical and family members to prevent it from getting to the point where it's unstageable. Mm-hmm. It should never get to unstageable, and it should never be a never event.
Mm-hmm. I agree.
Yeah.
So do you have any question for me, or do you want to share anything else that you can remember of?
Yeah, I just, you know, this is my way of giving back. I just feel when you see a wound that severe, how can you walk away and do nothing? So it's really, it's become my passion, not only for, to honor my dad, because he didn't deserve what he went through, but also to honor and to really help a lot of these family members who are struggling, and this is happening to them and they don't know what to do. So the best thing that I can just say to family members and to the medical teams is we need to communicate with each other and be transparent in the care. That way everyone's on the same page and you know what's happening and you can prevent it. And that's the biggest thing that we have learned, is this is preventable, and it's a major, major issue. And that's why I'm very passionate about speaking. And I'm not a speaker. I've learned to speak, and
you could be. You speak very well.
Well, thank you. I've learned to do it, but it comes from my passion in my heart, and it really is to honor my dad and to make things better, because we can do better. Mm-hmm. We can. So yeah, so it's just
totally agree.
For questions, I want to know what is happening in wound care. How can we get it in the forefront like this? How can we make change happen? How can protocols and procedures be consistent at all these facilities? And until that day happens, and if our story has a small part in making that change happen, then my dad's legacy is fulfilled, and we will rest and be at peace when that happens.
Mm-hmm. Definitely. So in terms of your questions, Linda, keep asking them. Keep asking them for anyone that you meet. And I think what is happening that we need to find more what is happening under the sheet, for sure.
Yeah.
To train, educate nurses, PSWs, not only them, but allied professionals. I would say that everyone are responsible for the patient. They should know. You don't need to be looking at patient's bump or under the sheet for knowing who are at risk of developing pressure injury, you know. Just by saying, for me, for example, I have a patient hospitalized for brain injury, and this patient is coming to the ICU. From ICU, he's going to be transferred to the other unit for recovery. And this patient is high risk for pressure ulcer.
Yep.
Or pressure injury.
And even sorry, Edie, even in the hospitals, if they had some on the walls, if they had something that, you know, with pressure ulcers, like when we went to Health Quality Ontario, I know it's probably reads backwards, but this was given to us. Okay. And this is pressure injuries care for patients. So this was given to us after the fact. So not
they created after. Maybe they created after everything, yeah.
This was given to us after our story hit the media. But why wasn't this brochure given to us at the time? We could have read up on it and educated ourselves on it. It's a simple little thing, but all you need to do is just mention the name pressure ulcer or wound.
Yeah.
People are starting to become aware of it, and it's really important. And movement. People get those patients moving.
That's what we want to create, the movement.
Yeah.
And creating change, okay? And this change will come from patient stories, from family stories, because sometimes people don't believe until they see.
Yeah.
We need to make them to see that it's happening. I want to share with you a little bit of my story with pressure injury. I became a nurse in 1997. And I went to work in hospital, big hospital. And then after working regular unit, I went to a more like a risk unit and kind of ICU complex care patient. And I noticed this patient was developing pressure injury. And I was like, that starts bothering me. I said, like, we need to do something for this. And it's very interesting because I heard this that time, and I heard just like a few months ago again the same thing from a physician saying, "This is normal. Don't worry about that. They all will develop it." Then for me, I was not conformed with that situation. So I started doing something, but I noticed we didn't have much equipment devices, like we didn't have coachings to turn the patients. Then we need to do some improvisation with a blanket. And in Brazil, actually, it's so hot, you know, it's tropical country. And this was back there. And I said, you know what, we have blankets that we are not using. So let's get a roll with the blankets. And on the blankets, but to not be too hot, we can put the sheets, and cover that, and then we tied and made the coachings. I start doing this movement inside of the ICU, and we start to see some decrease. But even though I start to see like you are wasting your time, this is not going to change, I decided to do my master in pressure injury. So I went to São Paulo, University of São Paulo. I had this professor that had just finished her postdoc in the US, and she was focused on pressure injury because in Brazil, we didn't have a lot of studies showing what is the incidence of pressure injury in Brazil. We know that this is happening somewhere, but we need to know the numbers so we can show to the government, they can invest more on these equipments and device. Mm-hmm. And we know that these people in determined type of units, they are more at a high risk. For example, ICUR, because they are, intubated sometimes. I understand, and this is something that needs to be transparent to the families. Your family member will come. There is a risk for pressure injury, but in the first few days, we can't move a lot the patient, but they still can do some relief of pressure, okay? They may not can turn totally on the side.
Yeah.
So there are many ways. So we start to do incidence, and another group is incidence and prevalence, but another group started to do education, because then we get the data and do education. When I moved to Canada, I said, I want to do my PhD again, like continuing pressure injury, but I want to do more like education, engagement with family. Exactly what you said. I know the family can do a lot.
Yeah.
And I was cut off when I talk about this with someone that was supposed to supervise me, saying, this doesn't happen in Canada. This is because I shared my story. I said, I've been doing this in Brazil when we have changed it. I want to know if we can continue doing something. I'm open. Like it is. This happened in Brazil, but not in Canada. Interesting, because I changed it. I changed my topic because anyway, I was a wound care nurse. I'm a wound care nurse, so could be any other wound. So I changed my topic for diabetic foot ulcer, which we have also a lot of problems, okay? But later, when I saw your daddy's story, that was the first time I saw any story in Canada, and I was like, see, this happened in Canada. I want to get a call, any call to this person and say, it is happening in Canada and it is being hidden. Nobody's talking about this.
Nobody's
and I want to talk about this, and nobody allowed me to do.
Until now.
Yeah.
Now people are talking about it. And that's where I am thrilled. And that people are talking about it. And I have so much respect for Wounds Canada, because I had people reaching out to me, but I didn't know what to tell them because I wasn't an expert. But, I forwarded them on to Wounds Canada, and I developed a website or a Facebook group that says Wound Care Aware. And where they could go on my group, and I invite you to go on. I'm just starting it up, or I've started a little while ago, but but it's for people that go on that site that have experience.
It's a website, or is a Facebook and a website, you said?
It's Facebook. It's called Wound Care Aware.
Okay.
And it's for people who have either experienced a wound, or it's professionals like yourself that can offer some help. And then when people ask questions, you can pipe on and just say, well, this is my experience. So it's more or less like a small group of people who have experienced pressure ulcers. And Wounds Canada has just been a huge support for us. We spoke at Queen's Park. I'm joining groups where I can help others, like Patients for Patients. I have reached out to several doctors who are in wound care, who are very elite doctors who I can't believe are talking to me. We got a story to tell, and I'm happy to provide from a patient's perspective what I went through, or what me and my family went through, because I think it's very important. So we've been very active in advocacy to really get this message out. And I always say I'm here to talk about it and to pave the path a little smoother for other families, so they don't go through all the bumps that we did. So, that's the only thing I can do. Helping others helps me heal, to be honest. And it's very
powerful. What you say is very powerful, because you're talking and you are, for sure, if it was more in the beginning, you would be crying mostly of the time here. No, in the beginning.
Cried. I've believe me, I've cried.
And now you are going to see that as you talk more. It is going to decrease. And don't blame yourself that you sometimes not cry anymore, because this is because you are healing, and it's going to stop. You continue with that dedication and awareness, and activism. but to the point where you have been healed, and then you are going to help others to heal as well, right?
And I probably cry once a week. A certain song will come on the radio. Whenever I put on that radio station,
I know.
that
I
one
know.
radio station, 92.1, where it's
Oh,
all oldies. When I put that station on, it reminds me of when my dad was in the hospital.
mhm.
So it connects me. It connects.
And thank you so much for trusting, for being compassionate and sharing this story. It's really important. It's really important.
Well, thank you to you both.